Puberty is not simply growing up. It is one of the most precisely orchestrated biological programs in the entire human life cycle. Before a single physical change becomes visible, a cascade of molecular signals has already been set in motion deep within the brain. In this video, we are going to decode the complete architecture of female puberty, the neuroendocrine engine that powers it, the 5-step developmental cascade it drives, the world standard staging system used to document it, and the 2 major clinical deviations that can break the timeline. Whether you are preparing for MBBS finals, NEET PG, FMGE, or the USMLE, this is the blueprint that ties every gynecology question on puberty together. Stay with me right to the end. The diagnostic matrix at the close of this video is worth its weight in exam marks.
Here is something counterintuitive that most students miss. The HPG axis, the hypothalamic pituitary gonadal axis, is actually active at birth and during the first few months of infancy before being powerfully suppressed throughout childhood. Think of it as a biological padlock. Between ages 1 and 8, GnRH pulses are kept almost completely silent. FSH and LH hover near 0, and the ovaries remain quiescent. The suppression is maintained by an inhibitory neural network involving GABAergic neurons and kisspeptin signaling pathways, a network that is not yet fully understood. Then, sometime around ages 8 to 10, that padlock begins to open. The inhibitory tone progressively lifts, and the HPG axis reawakens. This is the pubertal transition, the definitive transformation of a child into a reproductive adult, driven entirely by removing a biological brake that had been firmly applied for nearly a decade.
The engine of puberty has 4 components working in sequence, and you must know all 4 cold. First, the hypothalamus begins pulsatile secretion of gonadotropin-releasing hormone, GnRH. Critically, this starts during sleep only, around ages 8 to 9, a phenomenon detectable on overnight LH sampling. As puberty advances, the pulses increase in both amplitude and frequency until they occur continuously around the clock. Second, GnRH travels down the portal circulation to the anterior pituitary, which responds by secreting FSH, follicle-stimulating hormone, and LH, luteinizing hormone. Third, FSH and LH reach the ovaries, driving follicular recruitment and steroidogenesis. Fourth, the maturing follicles produce estrogen, specifically estradiol, which is the master hormone responsible for virtually every physical change of female puberty. This 4-step cascade, hypothalamus, pituitary, ovary, estrogen, is the HPG axis, and every pubertal abnormality you will ever be asked about traces back to a break somewhere along this chain.
If the HPG axis is the engine, what turns the key? 4 major modulators determine when puberty begins, and each one has been directly linked to conditions you will encounter clinically. First, genetics and heredity. Racial and familial differences in pubertal timing are well established. African American girls typically begin puberty earlier than white or Asian girls, and a girl's age at menarche correlates strongly with her mother's. Second, body weight and adiposity. This is where leptin enters the picture. Leptin is a hormone secreted by adipocytes, and it acts as a critical permissive signal for the HPG axis. A minimum threshold of body fat and circulating leptin appears necessary for puberty to proceed. This is why girls with very low body fat, such as competitive athletes or those with anorexia nervosa, can have dramatically delayed or suppressed puberty. Third, leptin itself acts as a neuroendocrine gate. It stimulates kisspeptin neurons in the hypothalamus, which in turn drive GnRH pulsatility. Fourth, excessive physical activity can suppress the entire axis through a combination of low leptin, elevated cortisol, and direct inhibitory signals.
The physical events of normal female puberty occur in a remarkably predictable 5-step sequence. Step 1 is the growth spurt, often the very first sign parents notice, driven by the combined action of estrogen, growth hormone, and IGF-1 on the epiphyseal growth plates. Girls typically gain 8 to 12 centimeters per year at peak velocity. Step 2 is Adrenarche, the maturation of the adrenal zona reticularis, which begins secreting androgens like DHEA and androstenedione, producing pubic and axillary hair. Note that Adrenarche is an adrenal event, entirely independent of the HPG axis. Step 3 is Thelarche, the first sign of breast development, specifically the appearance of the breast bud, which is the canonical first sign of central HPG axis activation. Step 4 is Pubarche, the further maturation and spread of sexual hair across the mons pubis and medial thighs, now jointly driven by both adrenal and ovarian androgens. Step 5, and the culmination of the entire sequence, is Menarche, the first menstrual period.
This slide is an exam classic. Students frequently confuse Adrenarche and Thelarche because they occur around the same time, but they have completely different origins and clinical significance. Adrenarche comes from tract A. The adrenal glands produce androgens, DHEA sulfate, androstenedione, testosterone, independent of FSH or LH signaling. These androgens drive pubic and axillary hair. Thelarche comes from tract B. The ovaries, stimulated by pituitary FSH and LH, produce estradiol, which drives breast development and general feminization of body shape. Why does this distinction matter clinically? Because premature adrenarche, isolated early pubic hair before age 8, often represents nothing more than early adrenal maturation and carries a benign prognosis, though it warrants monitoring for congenital adrenal hyperplasia. Premature Thelarche, isolated early breast budding, may represent benign transient Thelarche in toddlers, or it may be the first sign of true central precocious puberty. Breast budding, as a general rule, begins about 2 to 3 years before menarche.
Tanner staging, or more precisely, Marshall-Tanner staging, is the universal clinical language for documenting pubertal progress, and you will use it throughout your career in pediatrics, gynecology, and endocrinology. For breast development, there are 5 stages. Stage 1 is prepubertal, no glandular tissue. The areola simply follows the chest contour. Stage 2 is the breast bud stage, clinically defined as elevation of the breast and papilla as a small mound with increasing areola diameter. This is Thelarche. It is the hallmark of early puberty and has enormous diagnostic weight. Stage 3 shows further enlargement of the entire breast without separation of areola contour from the breast mound. Stage 4 is clinically distinctive. The areola and papilla project above the level of the general breast, forming what is described as a double mound or secondary mound. This stage does not occur in all girls. Stage 5 is the adult mature breast. The areola reintegrates into the general breast contour, and only the papilla projects. For the exam, Tanner stage 2 of the breast equals the onset of puberty. Tanner stage 5 equals adult maturity.
The Tanner staging system for pubic hair runs in parallel with breast staging, and the two do not always progress at the same rate in the same girl, a normal variation that frequently confuses junior clinicians. Stage 1 is prepubertal, complete absence of pubic hair. Stage 2, sparse, lightly pigmented, slightly curled hairs appear chiefly along the medial border of the labia majora. This is the earliest visible sign of adrenarche. Stage 3, the hair becomes progressively darker, coarser, and more curly, spreading upward toward the mons pubis. Stage 4, abundant, coarse, adult-quality curly hair forming an adult feminine triangle, confined entirely to the mons pubis. Stage 5, mature distribution, with hair extending to the medial surfaces of the thighs. A key clinical pearl: in normal puberty, pubic hair staging and breast staging are broadly parallel, but a significant dissociation between the two. For example, stage 4 pubic hair with only stage 2 breast development should raise the suspicion of excess androgen from an adrenal source, such as congenital adrenal hyperplasia or an androgen-secreting tumor.
Menarche is the undisputed clinical anchor point of female puberty. In most Western populations, the mean age at menarche is approximately 12.8 years, though it varies significantly by ethnicity, socioeconomic status, body composition, and geographic region. Menarche occurs because estrogen has sufficiently primed the endometrium, and the first withdrawal of estrogen causes the initial bleed. However, there is a critically important caveat that is tested repeatedly in exams. The first 12 to 18 months of cycles following menarche are frequently anovulatory. The positive estrogen feedback loop that triggers the mid-cycle LH surge and therefore ovulation is not yet fully mature. These early cycles are therefore irregular, often prolonged, and sometimes heavy. This is physiological, not pathological, in the newly menarcheal girl. Menarche normally occurs approximately 2 to 2.5 years after the onset of Thelarche, which is why measuring bone age and Tanner staging together helps clinicians predict how close to menarche a girl actually is.
Now we enter the clinical pathology section, and here is the single most important number pair you need to anchor in your memory: 8 and 14. Normal female puberty begins between ages 8 and 14. Precocious puberty is defined as the onset of secondary sexual characteristics before age 8 in girls. Delayed puberty is defined as the complete absence of any secondary sexual characteristics by age 14. These cutoffs are 2 standard deviations from the population mean, which is why they are used as the clinical thresholds. Understanding why these deviations occur requires you to think mechanistically. Is the problem coming from above, within the HPG axis itself, or from below, from the gonads or from an external hormone source? That central versus peripheral framework, combined with the FSH and LH biomarker, is the engine of your entire diagnostic approach. Let us now look at each pathological category in detail.
Precocious puberty splits cleanly into 2 mechanistic categories, and your ability to distinguish them determines your ability to manage them. Central precocious puberty, also called GnRH-dependent or true precocious puberty, is the normal HPG engine starting too early. The hypothalamus activates prematurely, FSH and LH rise, and the ovaries produce estrogen. Because the mechanism is identical to normal puberty, just time-shifted, the pubertal sequence is completely normal, just premature. Causes include CNS abnormalities, such as hypothalamic hamartomas, which are the single most common identified cause, astrocytomas, craniopharyngiomas, hydrocephalus, and prior CNS irradiation. Importantly, in girls, the majority of central precocious puberty cases, up to 90%, are idiopathic. Peripheral precocious puberty, GnRH independent, is driven by sex steroids produced outside the HPG axis. The brain is actually suppressed by the high circulating estrogen. Causes include ovarian cysts, granulosa cell tumors, McCune-Albright syndrome, exogenous estrogen exposure, and adrenal tumors. The key biochemical distinction: in central disease, both FSH and LH are elevated. In peripheral disease, FSH and LH are paradoxically low because the exogenous estrogen is suppressing the pituitary.
Delayed puberty also breaks into 2 mechanistic categories based entirely on where the failure sits. Hypogonadotropic hypogonadism is a central defect. The hypothalamus or pituitary is not generating adequate FSH and LH. Gonadotropins are therefore low or absent. Think of it as a broken amplifier. The signal is not being sent. Causes include functional causes, such as anorexia nervosa, extreme exercise, and chronic illness, including diabetes and renal failure. Structural causes, such as pituitary tumors and craniopharyngioma, and genetic causes, most importantly Kalman syndrome, a condition in which GnRH neurons fail to migrate from the olfactory placode during embryogenesis, producing hypogonadism combined with anosmia. Hypergonadotropic hypogonadism is a peripheral or gonadal defect. The brain is sending the signal furiously, but the ovaries cannot respond. Gonadotropins are therefore dramatically elevated. The single most important cause is Turner syndrome, 45XO, in which streak gonads are incapable of producing estrogen regardless of how much FSH and LH are thrown at them. Other causes include gonadal dysgenesis, premature ovarian failure, and gonadal damage from chemotherapy or radiation. The result in both categories is primary amenorrhea.
This matrix is the master key that ties the entire topic together, and I want you to photograph this in your memory right now. Two variables: origin of the problem, central or peripheral, and the FSH and LH biomarker, low or high. Low gonadotropins plus central origin equals hypogonadotropic hypogonadism, delayed puberty because the brain is silent. Low gonadotropins plus peripheral origin equals peripheral precocious puberty, early puberty because exogenous estrogen is suppressing the brain. The combination of high gonadotropins and central origin is physiologically impossible. If the brain is generating high gonadotropins, it cannot simultaneously be a central failure. So this quadrant is hatched. High gonadotropins plus peripheral or gonadal origin equals hypergonadotropic hypogonadism, delayed puberty because the gonads are deaf to the brain screaming. The key diagnostic rule that makes this whole matrix work: FSH and LH are low in central pathology and low in peripheral precocious puberty. FSH and LH are high only when the gonads themselves have failed. That single biomarker localizes the lesion.
Let me crystallize everything we have covered into 3 clinical frameworks that will serve you in exams and in clinical practice for the rest of your career. First, the engine. Normal puberty is the predictable reactivation of the HPG axis, GnRH, FSH, LH, estrogen, following years of childhood suppression, culminating in a 5-step cascade that begins with the growth spurt and is anchored by menarche. Second, the markers. Marshall-Tanner staging gives you a precise, reproducible visual language to document where a patient stands on the pubertal trajectory, for breast development and pubic hair separately on a stage 1 to stage 5 scale. Third, the diagnostics. Any deviation from the normal timeline of ages 8 to 14 is categorized first by origin, central versus peripheral, and then conclusively localized by FSH and LH levels. Low gonadotropins in precocious puberty means peripheral. Low gonadotropins in delayed puberty means central failure. High gonadotropins in delayed puberty means gonadal failure. Master these 3 frameworks and you own this topic completely. Thank you for learning with Studious. Please like, comment, share, and subscribe to Studious to help us reach more medical students who need this content.